what is an obviously very busy time for the NHS and your trust, the South Warwickshire University NHS Foundation Trust. We have apologies from Adam Carson, our Managing Director. Adam has unfortunately been taken unwell over the last month or so. Adam, we wish you a speedy recovery. We have apologies from Param Gill, Graham Nuttall, Jim Sinnott, and I think Simon Page. Do we have any other apologies, Sarah, please?
We do, Russell. So also Yasmin Becker, Phil Gilbert, Ollie Hisco, John Egan, Kelly Harrison. John Holland will be joining us later.
Okay, thank you.
Thank you.
Any new declarations of qualification for office or declarations of interest? Could you please raise a digital hand for me? Okay, I can't see any digital hands raised. There's just one from me for the public record, which is I am no longer chair of Your Cherished, a charity based in Sutton Coldfield, and I've given that up after 10 years, and that is a wonderful charity. And if ever you're thinking of charities to donate funds to, that would be a wonderful thing to help teenagers with self-esteem who self-harm. And the minutes of the meeting held on the 1st of October. If you weren't happy with the accuracy of those minutes, could you please raise a digital hand for me? Again, I can't see any digital hands raised, so I'll take us to, I think it's about page 21 of our pack, onto the matters arising from that meeting. And effectively, all of those points were complete, apart from the end of life committee, and that was being looked at by Fiona Burton to investigate the reasons for concern around the provision of oxygen to patients in the community. I don't think Ellie's on the line with us today. Do we have an update on that, Glenn, or can we provide that separately?
Can we provide that separately, Chair?
Of course. We also then had on the outpatient letter review group that Adam was to investigate the possibility of governor involvement in that. Sophie, do we know where we are with that?
Sophie's not with us yet. I'm sure that will be possible. Can we maybe that's something for General Purposes Committee?
Okay, if we take that forward, and then finally on the Salex project board, Adam to assist John Egan in arranging a visit to that project site. So can we just check that that's happened, Sarah, and if not, arrange it?
It is happening, yeah.
Okay, super. And I think that was all of the matters arising. If you feel I've missed a matter arising, again, could you please raise a digital hand? Okay, super. So we'll then get on to what is a pretty lengthy agenda. So hopefully members of the public won't mind us moving at a bit of a pace. But in terms of my general remarks, I'd be saying to members of the public that SWIFT, like all aspects of the NHS, is suffering from an enormous increase in demand and operational challenges at the moment. And whilst we don't get everything right at SWIFT, and I'm very clear that we don't, and on occasion we do get things wrong, the overall performance of your trust, I think, is something that members of the public can be very proud of. We regularly, in terms of the performance metrics, continue to register amongst the very top of the acute trusts in the NHS. And we continue to do a series of pathfinding bits of work in terms of integration of care paths, working with our community teams and working with other bits of the foundation group to ensure that we push what really are our three areas of operational challenge of productivity and flow and procurement around the strategic pillars, which Glenn will maybe touch on again a bit later. So we continue to get overall very strong feedback from our patients, our inpatient survey results, which I'm sure Glenn will touch on again a bit later, were amongst the very best within the NHS, which was very pleasing. And I can't thank enough our frontline teams who day in, day out cope with the enormous increases in demand that we're seeing. Unfortunately, we are a bit of a victim of our own success. And that, for example, in the past, it would be a very rare day that we saw 300 people arrive at our A&D. Now it's a rare day when we don't. And our A&D hasn't got any bigger. It used to be a rare month when we would see us able to deliver 300 babies. Now it's a rare month when we don't. So Swift, because of its reputation, is attracting patients and expectant mums from outside our geographical catchment. So we are a bit of a victim of our own success, but I can't thank the frontline teams enough. So without further ado, I'll move us on to the assurance items. And these are things that governors have requested assurance on and a briefing on. And members of the public may not be aware, but when it comes to later on in the agenda, you'll see the whole variety of different things that governors do get involved in. But one of the things they've asked for some assurance on is our approach to productivity. So Kim, I think you're going to speak on this now. Kim, over to you. Kim, I think you're on mute.
Sorry, I did that classic thing. Sorry, hopefully everybody can see my screen. So just as a reminder, I did take a more detailed productivity piece to the confidential sessions of the Council of Governors to specifically look at the productivity measures for Swift. But for the public session, we agreed that we would bring a productivity piece to show really our approach to productivity, to give members of the public assurance that we take productivity really seriously and how we actually manage to look at it in detail in the trust. So this is the assurance piece. So national picture of productivity. So there's a national tool that's been issued that looks at all organisations across the NHS and looks at productivity. And the national medium over the period that we looked at, which is comparing last financial year compared to the baseline year, which is effectively before COVID, the 2019-20 year, you'll see that there's been a national productivity reduction of about 13.5%. However, only 13 trusts have actually seen a productivity growth. So you'll see that on the top right-hand side of the page. And Swift and George Eliot are within the top 8 of those organisations. For benchmarking purposes, we've shown the performance of the other trusts in the group as well, but this is nationally available. So you see really that we're doing well on productivity. That doesn't mean, you know, we're complacent. There's obviously things that we still need to do, and this really demonstrates what do we do. So in terms of our governance structures, in terms of what we look at in terms of managing productivity improvement, we have a performance and productivity board. We also have an improvement board. We have our Excel in Everything programme and a number of underlying programmes within that, like the Outpatient Transformation Board, the Diagnostics Group, and also Nurse and AHP Bank and Agency Reduction Group, and also Medical Agency Reduction. So we just shared you some examples of the agenda items that we cover in those meetings. So they're really packed, and we look at all sorts of things from the GIRF programmes, theatre utilisation, you know, productivity, making sure that we are recording the activity that we're doing correctly, and making sure that we, you know, really drill down around, you know, our productivity and performance around like outpatient standards, etc. We also overlap that with staff development as well. So that's about supporting our, our teams around understanding what is productivity. We've done a recent event across the foundation group around operational managers, around training them around what is costing and productivity. We've also done a ward manager away day in terms of budget holder training and including understanding really what the cost drivers are. And order, as well as a clinical leaders development programme. And we've also done a number of away day sessions, not just with the elective care division, but more detailed away day sessions, looking particularly at those specialties within those divisions, looking at their productivity charts, which again, I shared examples in the confidential session. Model health system, again, it used to be called the model hospital system. It's a digital information service which is available to any NHS employee who registers, and it's a benchmarking tool which allows us to compare, a benchmark across the country and drill down to see if there's any opportunities, and we actively use that information and review in terms of our deep dives into specialties when we're looking at productivity opportunities. A measure really of productivity is what we call the WOW. So that's a weighted activity unit. So that's a way of effectively trying to standardise really the fact that, if you have an inpatient procedure, how is that comparable to an outpatient procedure? But we use this weighted activity unit in order to measure really the clinical output based on what we put in versus what we put out, and that looks at the volume of the activity that we look at. So that allows us to standardise and also allow us to compare. And what we've done is use that mechanism really for our own internal productivity trend analysis. So again, in the background, you will see some examples of how we've used that information to measure our own productivity and costs as well. And we're using this to standardise across the foundation group trusts as well, so that we can at least compare like for like and have meaningful conversations really around opportunities. Here again is an example of a template that we've produced in order to show the opportunities, insights and actions taken that is going to our performance and productivity board, where we're doing the deep dives. So again, that gives you assurance really that we're looking at all those different areas. Here again is an example of theatres productivity, which again is a new component of the model hospital, model health system, and drill downs available, and also our internal kind of Swift theatres dashboard as well. And all of these are looked at in a bit more depth in that board. And again, example of the outpatient transformation board, all the things that we look at, so we obviously, look over trends, and we do heat maps, as well as look at the national dashboards. And that's all about making sure that we reduce our DNAs, so do not attends, and making sure really that we are, again, picking up any opportunities that we may have missed. This is an example. I know it's very busy for you, but they're in the slides there. But again, there's a number of slides there of agency reduction to give you assurance again that we drill down at a really granular level, and we have lots of data that supports our decision making, but also supports the way that we try to drill down and reduce our agency and temporary labour spend. So there's a lot of work in the background, but as a council of governors, you don't necessarily see this level of detail, but wanted to give you assurance really that's a lot of detail behind the scenes that is accessible. We have a information portal called Spotlight, which all of NHS staff within the organisation can access, which is data protected, obviously. but they are allowed to access lots of information at their fingertips, really, if they wanted to look at productivity. It's all out there, and we openly share this information. I'll stop sharing now, so happy to take questions.
No, that's super, Kim. There's one question asked in the chat box. I think one of the points I would make to governors is we are an extremely productive organisation compared to other NHS organisations, but there's still big opportunities that we are hunting out. And one of the areas of opportunity is to ensure that medically fit for discharge patients are sent home, allowed to go home safely as quickly as possible. We regularly have around 40 patients in SWIFT who are medically fit for discharge, where because of issues around social care often, there's a delay in their discharge, which leads to us having capacity which is effectively wasted compared to what it could be used on in terms of improving our flow and potentially improving our elective activity. So if there aren't any questions, because I know governors have spent a lot of time on this at the moment, because we've got such a full agenda, I will move us on, but please do use the chat box, governors, for any points you want to make. And Mike Flaxman has already asked a very pertinent question. So we'll move on then to the next item on our agenda, which is the Trust's response to the Lord Darzi report on the state of the NHS. Glenn, you're going to give us a verbal update on this, but before you do, I do just want to recognise and thank Glenn. As well as being the Chief Executive of SWIFT, George Eliot, Worcestershire Acute and Wye Valley, Glenn is involved in a number of national discussions and work streams. So we're very fortunate to have you, Glenn, as the captain of our ship, so to speak. But Glenn, how are you seeing things around the Darzi report?
Thank you, Chairman. I see Roger's hand has gone up. Just it's gone down. Okay. Yeah, I mean the reason I'm doing a verbal update on this is I will include a little bit of content in the public board papers for our December meeting, and it's such a big subject. If anyone's had the opportunity to read Lord Darzi's report, then you can see it covers a whole range of issues, and it's a very well written critique of the NHS. I sat on the expert reference group, which looked at some of the data that went into the report and helped to reach some of the conclusions. And it's bigger than the issues and challenges that we face are bigger than just the NHS, is probably the best way to describe it first, because some of it is about the health of the nation, which is dependent on so many other things. As governors will know, that's a key part of our strategy to try and influence some of those other things. But notwithstanding that, there's a number of issues that the NHS could do better on, productivity being one of them. Kim's just taking you through where we are on that. But as you can see, whilst we still feel we've got opportunities for improvement, we're very much on the positive side of a broad spectrum of productivity performance there. So there is opportunity for us to reduce that variation within the NHS. One of the other things that it picks up on is the resourcing of the NHS, and that's always a bit of a political question. And we've just had a budget which has added some more funding to the NHS, but I think it's fair to say we will still be challenged. But one of the things that Darzi identifies is the need to address capital within the NHS. And I think there's two elements of that. One is to look at some of the new technologies, some of the imaging technologies that maybe other parts of the world have that we haven't got as much capacity in. And then the other one is just simply maintaining the NHS estate. Obviously we've got some local issues on that, which I could gladly elaborate on. Darzi, though, identifies three mission shifts for the NHS. One is to move from analogue to digital, the other is to move from hospital to home, and the other is to move from treatment of illness to more prevention. All of which actually are very well covered in the strategy that we've had across the trust and now across the group for the last few years. And we've made some reasonable progress on that, but there's still certainly an opportunity to shift that even further in those directions. And what I'm therefore hoping that will come from the next thing, which is the long-term plan in response to the Darcy report, it will be some better incentives and better mechanisms to allow some of those changes that we want to happen to actually happen more rapidly. So the timeline for that is there's a big public engagement exercise going on right now, and all members of the public actually encouraged to feed data into that. I was on a call with the Secretary of State this morning where there's been a very big response to that, which is good to hear. There's various working groups which will then be churning through that, thinking about some of the key elements that we need to include in the plan. Those will be meeting over the coming weeks, but they will have to conclude that work by the end of February. And then at the end of February, the report itself will be pulled together and we should see that final report in the spring. And that will then align to a multi-year cross-department government spending plan, which again we'll be looking to see whether there's some of the issues that the NHS, and I would say care, because part of this is the care sector, need to tackle in order to address some of those challenges. So we look forward to seeing that. I'm involved in one work stream, which is about the financial framework and the incentives framework that we should put in place. And I'm very keen to encourage ministers to look again at some of the freedoms that we used to have as a foundation trust that I think served us well and the local public well. And I'd like to see some of that kind of earned autonomy freedom to come back. So I look forward to seeing whether that makes it to the final report. So, Chairman, I'm happy to elaborate more on that. We talked a little bit about this when we had the Council of Governors Roundtable meeting recently, but otherwise I can move on to the performance report.
No, that's great. Thank you, Glenn. And I think we're all waiting with bated breath to the release of the 10-year plan next year so we can get on and deliver the level of healthcare and prevention that we want for all of our citizens. It's possibly worth saying, as a slightly jokey aside, Glenn, some of you may have noticed, is in a slightly different position. He's got a new standing up desk. I just say to all members of the public, sitting down is the new smoking. You burn 25% more calories if you're standing up. So Glenn is leading by example, and now has one of these very posh standing up desks to help him with his own health and well-being. But sitting down is the new smoking, would be my general point. So Glenn, please do keep us briefed on things as they develop on Darcy and the national work that you're involved in. But like I said, thank you very much for your endeavours. Shall we move on then to the operational assurance, please, Glenn?
Will do. Just before I move on to that, just to say, Jen referred to it as posh. It's a low budget NHS standing up desk, just to be clear on that. So I'm going to talk you through the Q2 update on the objectives for the year. These objectives are co-produced with our governors and identify a top level of priority activities. But beneath the surface of this, there's always so much going on in the organisation. And Chairman, you referred to the demand that we're seeing at the moment. Members of the public would encourage you to look at our board pack, which is in our public board papers, where we look through all the performance indicators. And also, when we meet together with the other trusts in the group, which we did in November, we look at comparative performance reporting, which always helps to indicate where we are. Yesterday, we had 341 A&E attendances. So it just kind of signals those numbers that you were referring to earlier. So I won't go through all of the elements of this report, but it's structured into our 4 big moves, which I'll just talk through, and then finally the pillars of our strategy. So the first big move is about being a very flexible employer, and you can see in the report we've been doing some particular work on anti-discrimination around a toolkit and a help desk, and that help desk is linked into our Freedom to Speak Up Guardian, so that's helping us to become aware of any issues that we need to tackle, either between members of the team or between the public and some of our staff. So that's helping us to address that. We're doing some work on neurodiversity. Then we move on to technology, and that identifies the EPR sign-off, which the electronic patient record sign-off, which has been something that has taken longer than we would have liked to get to the point where we've signed that off, but that's now been signed off. And we're doing a review of our digital hub, which is an area where we're looking at innovation around digital, which will help further with our productivity. And then some work around use of volunteers and reducing vacancies. And it's encouraging to see our vacancies have reduced. And Kim may reference this when she talks about the financial position of the organisation. It's good to see a reduction in agency spend associated with that improved recruitment. The next area is around Home First, so delivering more care out of hospital, which links to the DASI recommendations, and some work around discharge to assess. And we are mobilising what's called the Community Integrated Contract, which is where Swift takes responsibility for as a commissioner for out of hospital services, and that's something that will build over the next couple of years as we look at our role as a lead provider. And then we're also going through some more work on the detail of what's within our electronic patient record. The next area in the report is embedding prevention, and as again you can see some work that's been going on there. One really important area of prevention is around the early years work. So the 0 to 19 years contract, which is about to be re-let by Warwickshire Local Authority, Warwickshire County Council, who commission those services, is a really important thing that we're trying to ensure that we continue to be the provider of those services. So we're submitting an enhanced tender offer as part of that. Frailty, you can see there a reduction in readmissions of frail older patients, which is positive, and work continues to ensure that we can maintain that particularly over the winter. Ensuring that we bring prevention into a whole range of things, and one of the things that's referenced there is our improvement training. So a lot of that productivity improvement work that Kim referenced has come through the training of staff in improvement methodologies, and we've now added into that a training module on prevention, which is going to be adopted by the national team and included in the what's called quality and service improvement training for everyone. Then there's our leading on carbon reduction, some estate-related carbon emissions work. So we have another SALEX project, which is a non-interest bearing grant from the government to ensure that we move to zero carbon. And we're also out to tender for some more work on our green plan together with George Eliot. And then finally, we've been developing more awareness amongst our staff. We've got a number of green champions across the organisation, and we've also moved to a consistent methodology for looking at how much carbon we have reduced, and we're counting that in trees. So when you see future reports, you'll see the number of trees that each of our initiatives has saved, which we think is a good way to get people engaged in it. And then the final section of the report are those residual pillars within our strategy, and there's a number of things going on there, including our developing our research portfolio more, and some of the work about cost and productivity improvement that Kim's already referenced. So I won't go through all of those, and happy to take any questions.
That's great, Glenn, and as I hope members of the public can see, an enormous variety of work across a broad canvas being undertaken by the Trust. Any questions or perspectives from Governor colleagues? Can't see anything in the chat box, otherwise we'll move on to clinical governance. Okay, well, one of the absolute key priorities for us is the safety of our patients and the quality of the care we give. We have a clinical governance subcommittee of the board, which is chaired by Dr. David Spraggart. David, what would you care to pull out of your report?
Yeah, these are obviously the reports for August and September meetings, and for governors that have been to these meetings many times before. These are new style reports. Essentially, they just detail the key concerns, actions and assurances that we discussed at each meeting. And I think they're fairly self-explanatory, and I'm happy to expand on any elements if people wish.
But overall, David, are you assured about the quality and safety?
Yeah, I am overall. It's excellent quality that we've got, and it's quite clear. No trust is perfect. We certainly aren't. But I think we've got a wonderful culture that even if we were nearly perfect, we still wouldn't be happy with that. We'd want to be even more perfect. So I think we've got the correct culture within the organisation.
Okay, super. Thank you. Any questions from governors to David? Okay, thank you to governors who are involved in that work. We'll move on then to the financial assurance report. Sorry, as Mary Malloy has indicated, there's a lot of detail which is discussed at the Governor Patient Care Committee. So
yeah, we try to attend actually every month.
No, thank you, David, and thank you for your hard work. This is our most financially challenged year. We often say that, but it is getting more and more difficult to break even. Kim, how are you feeling about the money?
Yeah, I'd echo those words. I think, I know people say, oh, we say this every year, Kim, but, you usually have some opportunities. In the last few years, we've obviously had money given to us at a very late stage, really, and that obviously helps us really shore up the position and ensure that we can deliver our plans. I think it's fair to say with the recent budget announcements, a number of national finance calls were cancelled at the very last minute. And we don't actually know whether or not there's any scope. The headlines that we're hearing is that it's not enough money actually to fund some of the pay awards that have been agreed. So we're just working through that at the moment. So that's a considerable risk for us in particular, as well as many other organisations. So we're just working through that detail. But we've been told there's no money and it's going to be harder next year. So very, very challenging environment. If I go back to where we are, so this is the report for the month 5 position. So just as a reminder, really, at the last Council of Governors, I said that we had set a plan of £1.3 million surplus within a system deficit plan of £20 million, mainly driven by UHCW with a £25 million deficit, and all the other organisations being asked to make a stretched, improved surplus plan to offset that to a net 20 million. We were then told, was it last month? I've lost track of the months actually. Last month or so, that the centre had decided to help systems to deliver a break-even plan, and therefore gave non-recurrent support to systems to deliver that. So as a system, we were given an extra £20 million of cash back support. But we were also told that had to go to the organisation with the biggest deficit. So therefore, our plan did not change, but UHCW's plan moved from a £25 million deficit to a £5 million deficit plan. So I thought it was really important for the members of the public to be aware of that. In terms of our month 5 position, we are reporting a deficit of a £3.2 million deficit against a £2.4 million deficit for the month 5. We were planning to obviously improve that month on month in order to hit our surplus plan of 1.3 million. But I think it's fair to say it's really challenging. We did get some funding for the cost of industrial action that took place back in earlier in June, but it wasn't sufficient enough to cover our costs. And we've also enacted, obviously, the transfer of our estates and facilities services to Swift CS, which did help us deliver, as well as service operational gains, that there was a financial gain on the back of that. But I think at the moment, I would say that looks like we're behind on plan. So we need to do some more work in order to make sure that we have got further mitigations in order to hit our plan, or at least break even, which is our statutory duty. But in the context of, you know, a 22% growth from in ED, where we've got block contracts and we don't get paid for, you know, but obviously we need to make sure that we are ensuring that our patients are safe, and therefore incurred costs on the back of that to ensure that we're safe. However, we've done really well. I want to give credit really to the organisation in terms of their reduction on temporary labour spend. So you'll see in the pack, you know, we've almost halved really the our spend in comparison to last year in terms of our expenditure on temporary labour, and that's, you know, but also maintain safety, you know, and that's really important. So, you know, really, you know, thank you really to the organisation for supporting that. But I think it's fair to say that there's still some opportunities there for us to drive. And I've shared obviously examples of some of the data that sits behind these high level graphs that we use to actually manage that reduction as well. I've also shown the productivity, so you'll have assurance really that we're doing absolutely everything that we possibly can to ensure that we're being productive, but also productive in a way that helps us give us opportunities to deliver our activity, our elective activity, which actually comes with additional income opportunities. So making sure that we're doing the right thing there. But it is challenging. We've got risks, as you know. We're heading towards winter. You know, it is very busy and challenging at the moment. And I've also referred to the pay award risk as well, which is a national issue that we're dealing with. So that's the context. Thank you, Russell.
No, that's great. Mary's asking the question if there's any discussion at government department level regarding changing the way block contracts are applied to emergency department work compared to PPR. Glenn, what would your view on that be?
Yeah, there's been, so certainly the conversations are taking place, which is encouraging. Because one of the things that if we were paid on a payment by results basis, we would receive more income for urgent care. Just within our own system, actually, the balance of activity that's moved from Coventry and Rugby postcodes would be worth about £4 million this year. So we certainly feel it would be appropriate to move the income to where the activity is. It's probably not, it was certainly not going to happen within this financial year, but I'm hopeful that new financial framework that's being discussed as part of the long-term plan will take account of it.
Okay, thank you, Glenn. Thank you, Mary. Thank you, Kim. Clearly, in summary, a tough year. We'll do well to break even, but we're doing everything we can. We'll move on then to the audit assurance report. And Robert,
yes. Yep. Just briefly. I mean, we work through our cycle of business, so some of these things come up as a matter of routine. But we're be learning more about the Procurement Act that's coming in and how public bodies need to contract post-Brexit. So some changes there that we want to make sure that we're ready for. The kind of usual review of any deviations from following SFIs and SOs, and ensuring that policies are kept up to date. So those are sort of the three things that I'd highlight. On the kind of positive assurance side, we're exploring some integrated governance across our particularly audit and clinical governance. So we're making some progress there, and a good report on data quality on the 62-day cancer weights. One of the things that we do annually is we evaluate the effectiveness of the external auditor. And Deloitte was helpful in providing some of the information on their internal processes that'll help the committee evaluate that service. And of course, the committee each year, and we'll be doing this in the new year, will be evaluating its own effectiveness. So I'll be reporting back in future on that. But other than that, Chair, those were the main highlights from the meeting in September.
Thank you, Robert, and really great to have you on board. Oliver did a super job for us in the interim period, but it's great to have you as our new substantive chair of audit. Any questions or perspectives to Robert? Okay, we'll keep things moving forwards. we'll move on to the report from representatives of governors on their different projects and groups. I'm conscious of the fact I lose some governors as the day progresses. So with your forbearance, we'll start off with the Equality Delivery System Framework Group. Jane Knight, what's your update on this group, please, Jane?
Yes, I'm glad you've reached me now, because I do have to leave soon. Can you hear me all right?
Yes, I can, Jane.
Yeah, okay. It's just to say that I went to the Equality and Diversity meeting thinking it would be all about the general policy and how we go about it and whether we can improve it. But it turned out to be a tick box exercise in a way, in that there are all sorts of standards for equality and diversity which had been laid out, and the participants, of which there were 55, had to vote whether it was level 1, 2 or 3 on the different departments that they worked for. Well, being a governor, I had no idea at all. I couldn't participate, and I thought I was in the wrong place. So I just wanted to mention that, so that if you do have a working group, it might be a bit clearer next time what it's about. But anyway, so I haven't anything to say other than there are lots of scores between 2 and 3 and whatever.
Okay, well, thank you for that feedback, Jane. Clearly, equality, diversity and inclusion is an absolutely key part of our responsibilities as an anchor institution, but we'll take your feedback on going forwards. Any questions to Jane? Okay, I'll move us back up then to the Community Diagnostic Centre project. Mike Flaxman.
Thanks, Russell. Nothing really to add to the report that's on the table there. One correction, the next project board meeting is on the 27th of November rather than the 17th. My typo, apologies for that. And I'm rather hoping that at the next project board we will see the drawings for the health and wellbeing development, because I'm hoping that it will reveal what other space is being vacated in the new building as a result of the CDC opening, so that we can look at whether there's any possibility to move the MIU into better accommodation. So that's something I'll be looking at the project board on the 27th. And I know Roger Lloyd is very interested in the same thing. But nothing else to add. Thank you.
No, thank you, Mike. Thank you, Roger. I mean, it is exciting when one goes over to Stratford to see how quickly that CDC is coming along. Any questions or perspectives to Mike?
I just add that seeing the next two reports, I feel as if I'm shortchanging you by not putting photographs in.
Something for the future, Mike, something for the future. And on the subject of other exciting developments, we'll go then to the Elective Hub project. Graham sends his apologies for this, so we'll take it as read, but some really exciting developments on site. And I think if Glenn looked at behind him in his office, the speed at which things are happening on the Warwick Hospital site is fantastic. Glenn?
Yeah, I wasn't going to reference the view, but it is good to see it. The other thing, just to make governors aware, is there is going to be another opportunity to bid for national funding to support the elective recovery programme that's about to be announced. So we will be getting ourselves well and truly ready to pounce on that for the next phase of this project, which will be really important to us.
Okay, great. Thank you, Glenn. Any questions on Graham's report? Can't see any digital hands raised, so we'll move on then to the Ellen Badger Hospital site redevelopment. Again, something very important for the local community in South Warwickshire. Mike Wells.
Thanks, Russell. So I'll leave the paper as read, take it as read. We had a project board yesterday, and I spoke to the president of the Stour Valley Lions today regarding the men's shed. And because it was only going to be available until March, where I've said discussions continue and they're actually paused at the moment. The guy who was leading it's actually very poorly at the moment. So there aren't any volunteers. They didn't want to start it and then stop it. because it'll be a good group when it gets going. So pause for the moment. That's the only extra update.
Okay, thank you, Mike. Any questions to Mike? And then Michael Coker, I know it's been an extremely difficult couple of months, but any update on the End of Life Committee, Michael?
Yes, first of all, may I apologise. I did do a note of the last meeting, but I sent it in too late for it to be circulated. The committee met on the 1st of October, dealt with previous matters, and as always heard of a special case. This particular case is rather distressing insofar as a gentleman who was extremely challenged in many respects, but also was stone deaf. And the difficulty of actually communicating with him, except through sign language, and the difficulty that was experienced in the community in necessarily getting an interpreter or the same interpreter on subjects which were very, very sensitive. It did raise the fact that the hospital has that under contract, and as a result of this report, they're going to investigate whether in fact we can extend that into the community and therefore overcome difficulties of that nature. And I think that sort of thing is very, very important. Quality care end of life, I told at the last meeting of the 12 nurses, who've been trained on this and are operational now within the hospital. I understand that their actually work is very popular and in fact is passing on into the hospital, which is terribly important. More and more people are trained in the care of end of life. Similarly, the end of life champions, there are some 50 in attendance apparently the last meeting, so obviously the word is going out. Warwick Business School is carrying out a survey, but we're not quite sure what it's about actually though, because they're doing a general survey, so it may be very interesting what they advise us when they've finished it, but nobody seemed to know from the questions they were asking what they were after, but no doubt we shall find out. A point which may well come up, national audit care and end of life. This is something we do on a regular basis. We're finding, however, that people are finding it very difficult to answer, or we're not getting answers to that audit. It's thought by the professionals that this is perhaps the wrong questions are being answered. They're therefore looking into that because it does take up a lot of time, and they're beginning to wonder if it's really necessary, especially because we don't get results. And then SPICT, this tool, supportive and palliative care tools, are very essential because, as I understand it, perhaps some 35% of acute admissions are possible end-of-life admissions or people who are on that particular path, and ones where they're looking at making sure that those questions are answered at some stage so that they know specifically, particularly when people are perhaps discharged before obviously end of life, that the appropriate care takes place in the community. I say it every time. I'm really privileged to be on this committee because everybody seems to be very enthusiastic. Everybody seems to be interested in getting things done. And it really is, well, I suppose end of life is not meant to be pleasant, but in fact, they're a super committee.
No, thank you, Michael. And, you know, I often say the two most important things in my view we do as a trust, and our two most important responsibilities, is to bring life safely into the world and to help life leave the world with dignity. So thank you for that very comprehensive briefing. Any questions to Michael? Okay, we'll move on then to the External Audit Reprocurement Working Group. Back with you, Mike Flaxman.
Thanks, Russell. There's not a lot of visible activity at the moment as far as governors are concerned. Roger Lloyd and I met with Robert White and had a very good meeting on the 8th of November to chat through where Robert thinks the situation has got to. That was extremely useful. There is a meeting set up now for next Wednesday, next week, by procurement to deal with a lot of issues and basically the way to take the procurement forward. So it's looking at trust participation, setting up a project board and evaluation panel, the capability assessment, which is the report from the external advisors that were going to tell us if the market is interested in a for-trust bid, the timescales for the procurement, development of the specification, and the potential for a mini competition. So that's happening next week. It was set up at very short notice. I'm not sure I can attend it because it was only set up yesterday, a week away, which is a bit short. I think Roger and Robert can both attend, and I will try my best to get there, but I can't guarantee I will be there yet. Roger and I remain unconvinced that there are enormous economies of scale to get from a for-trust bid, because all these audits have to be done at the same time with individual partners, and frankly, I can't see there's much in it. I think at the end of the day, the tender will be, do you want to bid for all four, or would you like one of them, or two of them, or three of them? Because I don't think we'll get bids otherwise. Anyway, just my thoughts at this stage.
No, thanks, Mike. Keep us briefed. Any questions to Mike? Okay, we'll then move on to the Health and Wellbeing Hub Steering Committee. Carolyn, nothing to report, I don't think. We're still waiting for the first meeting, so
that's right, yes.
On that, thank you. And I've, in my enthusiasm, jumped over the Falls Prevention Steering Group. David G?
Nothing to report. The meeting was cancelled.
Okay, please keep us briefed, David, though, going forwards if it gets cancelled again. The Governor Election and Induction Working Group. Mike Ross?
Yes, this meeting's met a couple of times, and you'll start to see the results in the very near future. I think there's a splash on the front page of the website, Swift website at the moment, which is linking off to the elections. So I think nominations open tomorrow and go on till the 13th of December.
No, great. And again, I know some governors aren't standing again. I'll say it now and I'll say it in the future. Thank you very much. If you've decided not to stand again, thank you for the work you've done. And I'd enthusiastically encourage governors to stand again if they want to. And for anyone considering standing, again, I'd enthusiastically encourage you to put your name forward. Okay, so I think we are then on to the Medication Safety and Optimisation Committee. Mary, over to you.
Thanks, Russell. I'd like to apologise for there not being a written report. The meeting was only Monday this week, so I wouldn't be able to get anything in time for the papers. These meetings do cover a lot of ground and a lot of specialist details, so I've just picked out some of the key issues. And a detailed verbal report was given to the Patient Care Committee of Governors on Monday, so it is discussed in more detail elsewhere. There was no meeting in October. The October data was presented. There were 134 medication-related incidents in October, which is very little change from September, which is 135. However, the incidents with harm were now over 5% against a target of 4%. The incidents with harm and the actions that are needed to be taken or have been taken were discussed at some length, and I was assured that actions are being taken. EPMA and its place in ED remains an issue with the use of EPMA and paper prescriptions. But I again was assured that work is ongoing to resolve this. It was agreed that someone from the EPMA team should attend this committee in order to facilitate some of the discussion. The controlled drug audit was presented and it showed recent improvements in storage and use of controlled drugs have been maintained, which is good. One controlled drug incident is under investigation, but I am assured that the appropriate actions are being taken. The largest number of errors occur in the process of administration, and most of these have been identified as missed doses. This has been looked at in some detail, and I was very impressed by the amount of work that pharmacy have been doing on this. And there's some evidence already of improvement. One ward, for example, reduced its medicine omissions from 200 to 150 in a month. But drug shortages and non-formulary drugs on omission are adding to this problem. And it was agreed that in future, pharmacist prescribers may be able to help to prescribe appropriate substitutions. Borrowing of medicines between wards when there's a shortage of medicine on a particular ward was discussed, and a new procedure and a record form for this borrowing has been agreed. There's a waste and safety disposal audit ongoing, which has proved more difficult than they thought, but the pharmacy are working that through. There was a concern expressed over replacing plastic waste bins with cardboard bins as a green issue, but that was discussed. A medicine storage audit was carried out and was discussed in detail, particularly around storage of IV fluids, which should be treated with respect and stored in one place and in a lockable cupboard. So that was something that ward managers are going to be asked to look seriously at. And as usual, they looked at the recent safety alerts. This time there were only 3. But there's a lot of ground covered by this meeting.
Absolutely, as evidenced by your update there. Thank you, Mary, and thank you for your involvement. Any questions or perspectives to Mary? Okay, then we've got the outpatient letter review, which is still awaiting a meeting. So we'll come back to that as appropriate. Thank you, Pat. Then we've got the patient experience group. Sharon, any update from you?
No, apologies. I was off ill, so I missed the meeting, and Carolyn wasn't able to attend either. So
Okay.
I send my apologies.
Okay, no worries, Sharon. Lots of, Glenn didn't touch on it, but our inpatient survey results put us, I think, 3rd best in the country, Glenn, as I recall. So we can't be complacent, but really pleasing results coming out there. Nothing to report on the patient portal, I don't think. Pat?
Well, I can give you some figures just briefly from 2021 if you're interested.
Oh, always interested, Pat.
Right, okay. Well, yes, since 2021, all invitations, 470,128. First invitations, 162,081. Registrations, 120,144. Registration rate after first invite, 74.1%. Uninvited registrations, 3,459. And the date of their next meeting is the 19th of February 2025.
Thank you, Pat. I mean, I think that those numbers really do evidence the fact that the patient portal is proving popular with patients. Any feedback from patients or the families on how we can improve it further, I'm sure would be very welcome. But
sorry, Russell, to interrupt you. I'm just going to say that there is some confusion now, I think, amongst patients because of the NHS app as well. They're running side by side and people are not absolutely certain what's going on.
Yeah, no, I agree, Pat, and I think that does need clarity. And as Glenn indicated, the move from analog to digital, it needs to be in one place. But thank you for the update. Okay. The Patient Safety Surveillance Committee sounds slightly Orwellian. Carolyn?
Yes, you have my report from the 7th of October. There was another meeting this Monday. Would you like me to read out my notes from that?
Of course.
Yeah. Okay, so on the PSURF update, I can't quite remember what PSURF is, probably Patient Safety Incident Response Framework. On the previous report, there were 3 priorities noted. And one of the priorities, which is pathology, gynecology and pregnancy, the pathways are working very well now and forging ahead, and work is continuing on the other improvements. On the actual format of the committee, there's been from clinical governance some advice given, and the report is that we need to start thinking more broadly and strategically about safety, including maybe inviting other foundation groups to attend, looking at CQC gaps. Now, work is going to start on this, and there will not be another patient safety surveillance committee meeting until February, and it will be in the new format as long as that has been agreed. I don't know when in February, they say early in February, whether it'll be in time for the next Council of Governors, I can't say at the moment, obviously. The patient safety report provides an assuring position with progress being made to achieve local and national patient safety targets, particularly with focus on falls prevention and avoidance of pressure ulcers, which are the main problems, well, some of the main problems. The long-term plan is to free up patient safety team time for incident analysis and investigation and support, and by working to automate data streams, so more time for real work and less paperwork, if you like. They're continuing to work to move from RLD ATICS risk management system to IdeaGen, and a learning from deaths module is due to be launched, and a freedom to speak up module is planned. The patient safety newsletter, there's going to be a change from DATICS to IdeaGen stroke in phase, which will go live late in November, and will cover incidents, PALs, complaints, claims and inquests, and the risk register. And freedom to speak up and learning from deaths will follow. There will be a new information governance portal, which is a dedicated point of access for all staff from Swift, George Eliot, and Innovate. The next item is patient safety alerts.
You need to watch the time a little bit, Carolyn. Thank you.
Okay, well, there's going to be new connectors to prevent harm there. And there's going to be some change in the oxytocin overdose possibilities in labour and childbirth. The patients, yes, well, that's probably, I think that's probably enough. It is in the report to the minutes will have been taken to the patient care committee, so if any more detail, it will be there. Thank you.
Thank you very much, Carolyn. Any questions or perspectives to Carolyn? I think we're still with you, Carolyn, on the radiation protection.
Yes, apologies about this. It was 8:30 on Monday morning. They had to change it because of lack of staff to 1 o'clock on previous Monday, sorry. I couldn't attend, Callie couldn't attend either. I've asked for the minutes. If I get the minutes soon, I will send a report both to the Patient Care Committee and to the Council of Governors for next time.
Perfect. Thank you, Carolyn. Thank you. The Safer Discharge Group. Jean, what would you care to pull out?
Yes, I'll try to be brief, which is really difficult. They only met yesterday and they only meet every 2 months, and there's a lot of work going on. So I'll just raise the main points. First of all, the blood motorcyclists, it was planned for them to do all the late delivery of TTOs, tablets to take out, but it's not working out because, and I did wonder, they didn't realise just what a big job they were taking on. So they've now, they're still going to do it, but they're restricting it to 6 p.m, which obviously is an issue. So on top of that, we've already been working for the last 2 years. Most of the work in Safer Discharge has been about pharmacy. So we've now got 3 new pharmacists who will be independent practitioners by the end of December. So we're hoping that they will work with the wards and help alleviate some of the work that the ward doctors currently do. Ward doctors are very reluctant to write prescriptions out for takeout early, because they said they have to keep writing them and they're wrong and it might all change. But because of the pressure on beds, then the wards need it. We also are still finding that there are some wards or some members of staff on wards who don't know what to do when they've got a late or when they've got TTOs that need collecting. So with the big posters in every ward, and there's lots of info for them. So we're still people, even the the manager, she keeps getting calls from individual staff. So we're trying to sort that. What else? Technicians to be introduced next year, which we've been trying to get introduced for the last 2 years, which are operating at George Eliot. There were some teething problems with the forms, but I won't go into that. So we've sorted that. I'll speak about in the later session about urology and about some issues that have come raised there. The pressure sores, when they're admitted with pressure sores and then discharged to a different nursing home to the one they came in, it's been found that the new nursing home thinks that they acquired them in the hospital and is reporting as an incident to CQC. So we're trying to make sure that IT, paperwork, etc., actually records that somebody came in with a pressure sore, and that information is transported to the new nursing home. I won't go, there's a lot more, but I won't go into it because I know there's a lot to do. But I think the blood and the changes there, and the training of the pharmacists actually working on the wards is probably the biggest thing.
Okay, that's Gina. I think it does evidence two things. One is the enormous amount of work going on in this area to get it right, to provide safe discharges. But secondly, just for members of the public, Jean's update, as well as Mary's, illustrates the different areas that governors get involved in the way that the trust works. Thank you, Jean. Any questions to Jean? Okay, well, I think John Egan has had to send apologies, so the Salix Project Board will come to again next time. Callie has had to give apologies as well, so the Serious Incident Review Group verbal update will have to carry forward to the next one as well, but obviously that work goes led by the executives. The Wayfinding Strategy Group, Roger, anything to report here?
Beyond the report for the previous meetings, we did have a meeting on the 7th, which was 7th of November, which was too close to allow me to update this report, which that meeting got half abandoned due to a power cut in Lake Inn Road. So everyone on the call in Lake Inn Road vanished and stayed vanished. We did get a brief comment about the CDC in Stratford on progress, and the agreement about the style of the notices, notifications, etc., which will go up in Ellen Badger, because that particular project manager wasn't in Lake Inn Road, he was elsewhere. Beyond that, no, all the only other point which is relevant, the Living Maps project has gone live, but unfortunately, under the pressure of going live, 1 or 2 more glitches have been found in the system. Everyone's working to get it cured, but it's not perfect now, but it is hoped that it will improve within the next month, as the glitches are in the software are evened out.
Thank you, Roger. Keep us briefed on that, because as we all know, finding our way around hospitals, particularly when we're under stress and worried, is incredibly important. So a very important piece of work going on there. Any questions to Roger on wayfinding? By the end of this, Roger, you'll be one of the leading experts in the NHS on wayfinding, I'm sure. We'll move on then to some governance matters. and minutes. The first is the General Purposes Committee approved minutes of the 11th of July and the meeting report from the 10th of October. And Mike Wells?
Thanks, Russell. I'll take both as read. If someone's excited enough to read the whole minutes, you'll see the full breadth and depth of everything we get up to, and the shorter versions in the report. So just take questions if there are any.
Thank you, Mike, and thank you for your leadership. Any questions or perspectives to Mike? Okay, then similarly, the Patient Care Committee approved minutes of the 9th of September and the meeting report from the 14th of October. Andy, anything you'd particularly like to pull out?
Thank you, Russell. No, I think only just one thing. I take the minutes as read. This is a very active committee, which I'm delighted to be part of, and it is a very challenging group of committee members and governors. Two things that I think we're kind of proud of is that the TTO responsibility of the volunteers, as we've heard from Jean, has been taken over by Blood Bank. So that allows them much more time to devote to other volunteering activities, which they're grateful for. And then secondly, we have set up a system whereby we learn of concerns from the community, which we take straight to the relative departments. And we do get compliments as well, and we send out emails to the individuals and departments to report of the success and hard work that they've done. And that's about it. Thank you, Russell.
No, thank you, Andy, and thank you for your involvement in it. Any questions to Andy? Okay, I think then we're on to the membership and engagement update. I know a paper's been circulated on this today, so what would you care to brief us on?
So it's just to say that work on the Trust's patient and public engagement strategy is continuing, and the Governor's received an update on the current position by email this morning. Governors will be asked to fill in a questionnaire about how they engage with members of the public and Trust members in their constituency areas, and that will feed into the overall strategy. And a further discussion will take place at General Purposes Committee about the future requirements of the Membership and Engagement Committee. Thank you.
No, great update. Thank you, Sue, and thank you for circulating that paper earlier. Any questions or perspectives to Sue? Okay, we'll move on then to the report on resignation, appointment and election of governors. Sarah?
Thank you, Russell. So just to confirm that we've had no resignations or appointments made since the last report to the Council of Governors. As reported earlier, the governor election process opens tomorrow with the nomination stage. So depending on what Trust members and current governors have stated their preference to be, keep an eye on your inbox or your letterbox for the nomination pack. Happy to take any questions. Thank you.
Thank you. Any questions to Sarah on the report on resignations and appointments? Okay, so we're then on to the annual self-assessment of the Council of Governors for 2024, which will take us read. It's quite a big pack. Sarah, anything you particularly want to say on this?
Yeah, and the report was previously considered by the General Purposes Committee, and I thought it was important just to pull out some of the points that were raised at the at the General Purposes Committee when they considered the feedback in the questionnaire. So first of all, thank you to the governors that did undertake completing the questionnaire, as your input is valued. So some of the responses received related to engaging with members, which was felt to be a low response of engagement. However, the GPC felt that governors should use their links and community groups to improve their engagement with members of the public and Trust members within their constituency area. There were comments that were made around limited opportunity to question the Trust executives. Again, it was noted that governors do have opportunities to attend the public board meetings, and that governors can submit questions to the board meetings, whether they're present or not, which does enable the Trust execs to be challenged and to answer those questions for the governors. There were comments around the lack of face-to-face meetings. It was felt that virtual meetings can be more productive, and that in taking these points on board previously, that the roundtable events are now held face-to-face. And the roundtable are opportunities for governors to influence the trust strategy, which also received a range of responses for those questions. It was felt that there was positive feedback generally, but also some conflicting comments. So they were the main points discussed at General Purposes Committee. So I'm happy to take any questions. Thank you.
No, thank you, Sarah. And as you said, thank you to governors who kindly took the time to fill out the self-assessment. And as ever, you know, whilst none of us are perfect, if you would like me to be doing anything differently as your chair of the Council of Governors, please let me know. Feedback's always welcome. But I would say that I think as a corporate, the Council of Governors here is a very effective grouping, as evidenced by all the reports we've heard today. Any questions to Sarah? Okay, so we'll move on then to the calendar of meetings for 25-26. Our life goes before us, Sarah.
It does.
Read.
Thank you. Just to note that although the new council will be in place from the 1st of March, obviously we need, from a governance perspective, we need to put these meetings in place for April onwards. So they're here for the council's consideration and approval, please.
Okay. If you're not happy to approve, could you please raise a digital hand? Duly approved, Sarah. Thank you, and thank you for the work that goes on behind the scenes on the admin. You and Sue do a great job for us, and Verity's been a fantastic addition to the team. And the lead governor annual report, Mike, anything you'd like to pull out of this?
Yeah, thanks, Russell. There are three things really. One, I think has actually been mentioned today in this meeting. It was also mentioned in the cancer services review we had this morning as governors. And that's the impact on our performance of our partners. Very concerning and frustrating. I'd like to thank Sue and Verity as well. They've kept me out of trouble. They've organised all the governors, so thank you to them. It's much appreciated. And Sarah's also kept me out of trouble. And I'd like a big thank you to all the trust staff everywhere. They're amazing, and we're really proud to help them.
Thank you, Mike, for those kind words. Any questions or perspectives to Mike on the lead governor's annual report? Can I just thank you, Mike, for stepping into the breach and taking up the role. It's always easy to take a perspective when you don't take up the role, but you and before you, Mary, have been great lead governors for us. So we're blessed to have you. Thank you.
Thank you.
So we've then got some changes coming up with our NED. So we have recommendations for the appointment of vice chair and change to non-exec director voting rights. I was going to go on this, Sarah, but I'm very happy for you to.
Sorry, I was just going to say you've missed item 8.8, which is the appointment of the lead governor. Sorry, Russell.
I tell you, it's okay. Sarah, the appointment of the lead governor.
Thank you. So annually we have to appoint a new lead governor. The paper sets out the requirements of that role, and I am pleased to say that Mike Wells submitted an application to be lead governor again for another year. So this paper proposes that we appoint Mike as the lead governor. So seeking the Council of Governors approval, please.
No, thank you. If you're not happy to approve Mike, who's kindly put himself forward again, could you please raise a digital hand? Unanimous approval, Mike. Thank you very much. The appointment of a vice chair. We lose Simon Page next year. He has to leave us. And I'm recommending that David Spraggart becomes the vice chair at that point. A number of us know David from many years of experience in our system, and has been an absolutely leading example of a GP and a leader role within the GP and primary care position. If you're not happy to approve David as vice chair, could you please raise a digital hand? Okay, thank you, David, for willing to accept the role, duly approved. And then in terms of non-executive director voting rights, we lose Sue William-Tracy next year as well. So the suggestion is that Oliver Koffler becomes a substantive voting NED when Sue leaves us. Again, if you're not happy to agree that, could you please raise a digital hand? Duly approved as well. Thank you, Oliver. And then we've got the reappointment of a couple of non-executive directors. Roger?
Thank you, Russell. The report is straightforward. It's clear. The Nominations and Remuneration Committee consider this and recommends to you that we reappoint Phil Gilbert for 3 years on his term to the 6th of March 28, and we reappoint Paramjit Gill again for another 3 years, in his case to the 31st of March 28.
Thank you very much, Roger. If you're not happy to approve these recommendations, could you please raise a digital hand? Okay, duly approved, and thank you, Roger, for your chairmanship of that subcommittee. We then move on to any other business. Any other business, please raise a digital hand. Any questions? Sorry, David.
Thank you. One point I'd like to raise, if I may. Last week I carried out a survey of the Leamington Spa Hospital, and I was very concerned at the number of areas where the gutters are blocked with grass and weeds and small trees, with the consequence that water is running down the road, down the wall in many places, which can cause moss to start growing. But also, if a gutter is full of water, what is not realised is when you have driving rain, it can also at the top go upwards and into the eaves in the roof. So this is something which has been ongoing for an awful long time, and it never seems to be addressed.
Yeah, thank you, David. Glenn, I think if you and I can take it forward, apparently Kathy Wagstaff has sort of mentioned to me that she's popped it on, I think it's a Planet X estate system, and it then disappears. So if we can maybe take it outside of this meeting, but there does appear to be something going slightly wrong on the maintenance programme over at Sarah.
Yeah, and also I'll check that it's not a wider issue.
Yeah, no, that would be great. Thank you. Any other questions from governors? Now, in terms of questions from members of the public, I think, Sarah, we've had one or two.
Yes, Russell. So we've received a detailed question from Janet Ruane, who is in the meeting today, regarding a patient matter that I think you were going to respond to. Yeah, thank you. Ms. Ruane, I note the fact that there has been correspondence from us to you on this. As it's a patient matter, though, I'm concerned about it being discussed in this public forum. So I know you are having discussions with our PALS service, and I'm very happy for you to continue to communicate with Glenn Burley as Chief Executive and myself as Chair. But I don't think it's appropriate to go into patient level detail in this type of meeting. So with your forbearance, if we can continue to address it with you directly. But both Glenn and I are happy for you to continue to write to us, and we'll continue to ensure your concerns are addressed through the appropriate processes. Any other questions? Roger, you asked a question earlier, which I think was addressed in the chat box by Glenn. Were you happy with that reply? We can't hear you, Roger. I can see lips moving, but I think you're mute.
You're still on mute as far as I can see.
Which Roger are you after?
No, Roger E, not you, Roger. Yeah.
Right, thank you.
I'll just wait a second to see if you can get off mute. Technology, don't you just hate it? Just bear with me. I'll see if I can help by taking you off mute.
No, I've just tried, Russell, and it's not a function that we can do.
No, Roger, apologies. We're unable to mute you, but you're still showing up as muted, so we can't hear you. If you want to pop something else in the chat box, that's fine. But the only thing I would add to what Glenn said is the whole issue of the assisted dying bill is a very difficult issue, a very moral issue. But at the end of the day, the NHS will do whatever Parliament decides. Glenn, is there anything you want to add to that?
Yeah, I would have said the same, Russell. I mean, for members of the public watching this, they don't know what's in the chat. So just, it was a question from Roger about the comments in the newspaper, that a statement had been made that there was an extra cost to the NHS of implementing the recommendations, which I understand is what the Department of Health is saying. I've not seen how they've calculated that. Obviously, the proposals that are being debated in Parliament may or may not be anything that is implemented, or they may be changed. But we will try and keep close to that. And as Russell said, if that is what Parliament instructs us to do, then we will implement it. And hopefully, if there is an extra cost, that will be resourced.
Okay, thank you. And then I can see a hand raised by Janet. Sorry, Janet, I don't know your surname. I apologise. Janet?
Thank you, Chair. Thank you. You've seen my question.
Yeah.
I rather feel that you've taken advantage of the fact that I put that question in writing, as I was asked to do in advance of the meeting, and now you've indicated you're not willing to let me speak. The point of raising my...
If you'd like to raise it, then please do so.
Thank you, Chair. The point of my raising the question in this forum, I appreciate this is not the usual forum for a particular case. The point of my raising my concern is that my correspondence to Mr. Carson, to Patient Experience and to PALS has been ignored for months and months and months. And my correspondence relates to an investigation report into the death of my late husband. He died last year at Coventry Hospital, having been at Warwick Hospital. I raised my concerns last year. Mr. Carson appointed a consultant to look into those concerns. He produced an investigation report in April. I was invited to respond to that investigation report, which I did in May this year. Since then, I've heard nothing, or I've had very brief acknowledgements from Mr. Carson's department and from Patient Experience. Last month, I emailed yourself. I CC'd in the governors by way of the group email, and I've had no acknowledgement or response. So my question is, why is it that I've not received a substantive reply to my correspondence dating back to May in relation to an investigation report into my late husband's care here at Warwick? By way of update, because I submitted my question in advance or not, yesterday I received an email from a member of staff on behalf of Mr. Carson. Very brief email, and I'll read that to you. I have reviewed your letter of 21st of May. I found it was shared with Dr. S, the lead investigator. I have contacted him today, i.e. November the 12th, to obtain a response to the points you raised about the investigation report. So in virtually 6 months, nothing has happened. I'd like to point out that in the papers you have as a committee and a council looked at today, in your minutes of your meeting on the 1st of October, you said of particular focus during Q1, the focus had been on improving the timeliness of response rates to complaints. And in reports to the Patient Care Committee from the Patient Experience Group, it is recorded that the time frame to resolve formal complaints is 40 days. I raised my concerns well over a year ago, over 52 weeks. And so whilst I appreciate this isn't, as I say, the normal forum for an individual case, I could see no other option. And I also believe that my experience as the widow of a former patient shows that there are serious failings in the complaints process and failings in the Trust's oversight of process. Thank you for letting me articulate these concerns.
Thank you, Ms. Ranger. We're all very sorry for your loss. So I obviously was aware of your email. I've looked at the correspondence that has gone back from us. Glenn, is there anything you want to add?
No, I mean, I'd certainly apologise that you've not had all of your questions answered. I will pick it up personally with the PALS team to see where we are with getting those responses to you. I would rather we answer everything fully rather than necessarily hit a deadline of response times, but I completely understand from your perspective that that's gone on too long. So I apologise and I'll have a look at it myself.
Thank you.
Okay, thank you. Any other questions from members of the public? Okay, ladies and gentlemen, I think that brings to an end our meeting today. We'll have the adjournment to discuss the confidential Council of Governors meeting, which will start in 5 minutes. In the meantime, can I thank so many members of the public for joining us, and we will get back to you all in due course as speedily as we can. Take care, everyone. Bye-bye.